Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for June is Child and Youth Mental Health. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices located in Ottawa are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this community, our province, and the country. Today, we're delighted to speak with Maisha Saida to bring you collaborative pathways to engage healthcare professionals in addressing refugee, child, and youth mental health. Before we begin, we invite you to answer a few quick poll questions for us. Please note you'll have to answer all 3 questions to submit your response. While you're doing that, and thank you so much for doing so, I'd like to introduce our speaker. Dr. Maisha Saida is a clinical scientist at the Center for School Mental Health and adjunct research professor in the Applied Psychology Division in the Faculty of Education at Western University. She is a licensed clinical, school, and counseling psychologist in Ontario. Maisha is a community-based intervention researcher focused on developing, evaluating, and implementing multi-tiered interventions to promote positive youth mental health and resilience of newcomer children, youth, and families. Additionally, she researches training and supervision modalities to promote anti-racism and anti-oppression in clinical practices effectively. She holds a clinical and supervisory appointments at the Mary J. Wright Child and Youth Development, affiliated with Western University, and the Toronto Psychology Centre and Sunrise Psychology. It's now my pleasure to pass the mic to Maisha.
All right, good morning, everyone, and Eid Mubarak to anyone who's celebrating Eid al-Adha today. Thank you for taking the time to spend an hour learning more about how we can collaborate with each other to enhance the support to provide services to refugee children and youth. And I will go ahead and share my slides right away. All right. As introduced, I am a licensed clinical child and adolescent psychologist here in Ontario. And in addition to my clinical work over the past almost 4 years, I have been doing intervention research to support refugee children, youth, and families. And the information and the conversation that I bring in today is not only inspired or learned from the work that we do through research, but a lot of the learning comes from some of the direct conversations, the stories, and the experiences that I've heard from the community members who provide direct services to refugee children, youth, and families, as well as the refugee children and youth groups that I have the privilege to support as a researcher as well as a direct practitioner. I would like to begin with a few shared agreements for our webinar. I want to acknowledge this is a flexible learning environment. I know that we are quite busy with a number of commitments that we have both in professional and personal domains. So I'm grateful that you have made this commitment to take some time aside for our learning. But that being said, sometimes things may come up. So whatever you need to do to excuse yourself, please feel free to do so. I believe that over here, many of us may come with diverse knowledge and background and experience. And this knowledge may not only come from some, stereotypical historical ways of knowing that was only approved by westernized lens, but many of these experiences and learning could also come from the direct work that we provide through different interlocking identities and experience that we have or our interaction with community. Throughout this conversations and our webinar together, we would be talking and highlighting about some of the difficult and stressful and sometimes painful experiences that refugee children, youth, and families experience. These conversations, these stories may bring up personal memories of maybe folks you are really close to, maybe your own, or maybe clients and families that you are supporting as a healthcare professional or trainee. So if these conversations are painful for the body and the brain, again, please do whatever you need to take care of yourself. As have been mentioned earlier, there are times set aside at the end to have a more open, reflective, and responsive discussions throughout the webinar. I would pause and invite people to engage in few reflections based on the work and the practices they're engaging in. There is not a demand that everybody needs to openly or verbally or through written form respond to those discussion questions, but do I invite you that even privately through your own, if we could engage in those reflective discussions, it would be important because they will sort of indicate and direct to us as to what are some next steps that maybe we need to engage in order to do this work within our practice settings. So you folks have signed up, and I did provide an initial description of the webinar, but just to remind ourselves and guiding us what we are going to talk about for the next 30 to 40 minutes. It is my hope that through this webinar, we are expanding our knowledge of systemic etiologies that might explain the possible development and expression of mental health distress and disorders in refugee children, children and youth groups. The one of the main or the common theme of this webinar is really to think deeply and also strategically and innovatively as to how we could co-create collaborations. And an important facet of the collaboration would be considering how do we collaborate, how do we do assessment and develop referral pathways to begin to address some of the access barriers that exist for mental health supports and services. And I would agree not only for refugee children and youth, but other folks who are marginalized and minoritized, as well as start to consider how can we develop effective and equitable community partnerships between and among different sectors to improve access to mental health care. So let's begin by setting the context. So we are talking about refugee children and youth, and sometimes, due to historical stigma and shame and discrimination that these populations have experienced, particularly in Canada, we tend to use a more umbrella term such as newcomer. But I have decided to use the term refugee children and youth for this webinar, and sometimes for some research and clinical work I do, because it's important for us to position and contextualize the diversity of experiences, the diversity of migration journeys, and the diversity of resettlement resources and experiences that, depending on migration journeys, our newcomer families might experience. So in Canada, broadly, there are three different categories through which someone can move to Canada and begin to apply for the application of permanent residency. The first one is economic and skill-based immigrants. The second one is refugees, asylum seekers, and protected persons. And the third is temporary residents, such as international students. It's important for us to contextualize and remember that most immigration still today comes from economic and skill-based immigration pathways. In order to be approved for economic and skill-based immigration pathway, people need to demonstrate certain existing economic and educational and financial privileges in order to get approved. And then due to, and I think over, since 2014 and 2015, due to the increases of wars and political and climate and other geographical crisis, we have seen an influx of refugees and asylum seekers who are moving into Canada. One reason why it's really important to distinguish, and especially within our conceptualization as healthcare professionals, as to why these pathways are different, is in many of the cases, economic and skill-based immigrants, there might be geographical or local tensions, but to some extent, economic and skill-based immigrants have somewhat of a relatively greater autonomy and agency in making the decision to move to Canada. And what helps to make the decision is some of the existing assets and resources you might have. Some of these stereotypes and myths I often hear from folks is how easy it is just to move to Canada. But it's extremely difficult. It's based on a point system. You have to gather a lot of documentation. There's an interviewing system. So it's not as straightforward, and there's a lot of processes that go into it. However, for refugees and asylum seekers, especially those who are the most vulnerable, at times they are displaced from home. And they're displaced from home, and many of us might already know, and we'll talk more about it, especially in relation to mental health. There isn't a lot of autonomy and agencies in the decisions they're making about their movement and migration. Many of the times they're within days, they're displacing from their home. They're in their routes, there might be different migration camps, and whether they're getting sponsored privately, whether they're getting sponsored through UNICEF or other government, a lot of decisions about migrations is being made by others rather than themselves. And that loss of autonomy and agency has huge implications in a person's well-being. And that is an important conceptualization for us to consider as healthcare professionals. To share some stats, between 2015 to March 18th, Canada has resettled about 100 refugees, and around 43% of them were under the age of 18. And this influx was seen mainly after the civil war and other international crises that we have seen in Syria, as well as in the Middle East. In more recent years, Canada, for example, last year, Canada has continued to welcome refugees and protected persons. Last year, Canada welcomed around 75,330 resettled refugees and protected persons. But something that we need to, again, conceptualize and pay attention to, that most of our migration in Canada still comes through economic and skill-based immigrants. As you can see from the statistics that is reported by Immigration, Refugees and Citizenship Canada, only 17.2% of migration is accounted by refugee and protected person migration pathway. Now, if you look at the top 10 countries from where newcomers are coming into the country, again, these are for all permanent residency numbers, not just for refugees. This includes both refugees and immigration, as well as temporary residency pathways. As we can see, here is the top country. India is We're getting most of our newcomers from India, followed by China. However, in the past 2 years, we also have seen a surge in refugee and immigrants moving from Afghanistan as well. And of course, in the last almost now 10 years, we have seen that influx from Syria as well. Again, why, as healthcare professionals, are these just stats we are learning just to enhance our overall curiosity and knowledge? But these stats are also important in terms of understanding that when we think about additional language services that we might need to incorporate and integrate, these stats are helpful in understanding that what kind of additional language support we might need. So from this list, one of our first indication or hint as to what might be one of the most common additional language service need would be Dari and Farsi due to migration directed from Afghanistan, as well as Arabic. So for refugee children and youth, our research over the past decade has made it quite clear, and I don't think there's a debate about it, that due to different individual, familial, and systemic risk factors, they could be at increased risk for developing and expressing mental disorders. Some of the cross-sectional and prevalence rate research that has been done in refugee camps or as well as initial stages of resettlement in high-income countries, including Canada, Sweden, United States. The prevalence rates do tell us that some percentage of refugee children and youth might become, might be exhibiting symptoms that might meet the diagnostic criteria for post-traumatic stress disorder, depression, and anxiety. And the risks are higher than those who are born in the high-income countries. And the reasons why these prevalence rates might exist is due to the interaction among and between these individual, familiar, and systemic risk factors. So just going to details on them. So at the pre-migration level, there is risk that children and youth are directly, if not indirectly, exposed to violence. Violence, not just, hearing or seeing wars or battles or other violent incidents, but they might also lose their family members. Sometimes they witnessed death of their family members or separated from their family members. In order to prioritize their safety, many of these times children and youth have to, again, as I mentioned, right away have to escape or displace from their family members. And many of the times there might also be separation. Especially during some of the international crises and some of the wars, male adolescents might be at greater increase of risk of being recruited. Men in general might be greater risk of being recruited into different militia. So there might be separations. The children and youth might be separated from their parents, from their older brothers or siblings. During migration, again, very rarely that we would see, especially in refugees and asylum seekers pathway, that the family is directly moving from their home to Canada or other high-income countries. In their migration pathway, they're likely spending they're spending time in some regions, whether it's in Africa, some parts of Asia, or Europe, before they're approved as a protected person or as an asylum seeker or as a permanent resident to move to Canada or elsewhere. But that's really important for us, again, as healthcare professionals to really conceptualize and consider that what is happening during what we called during migration period. Refugee camps are stressful from different domains. There might be continuous separation from family members. There might be interruptions in schooling, even though there might be some sort of accommodations or support provided in refugee camps to support with basic literacy, but many of the times it is not paralleling or mirroring to what a structured schooling environment might look like. Even within the local region, in the refugee camp, the child and youth and their families might continue to experience racism, xenophobia, Islamophobia, and discrimination. Um, Sometimes, again, it's not uncommon for us to hear stories and events of sexual, emotional, or physical violence in a refugee camp. There might be financial stressors, there might be, physical stressors, just even physically the space that they're provided to live sometimes for months, a sense of food insecurity, the quality of food and nutrition that the families are receiving. But again, from psychologically and socially, again, that lack of agency and autonomy, there is a great deal of sometimes uncertainty and insecurity and unpredictability about how long they would be allowed to stay in the camp, how long they have to stay in the camp, and which country would finally give them sponsorship in order to move back. But again, as you are living through this, your own personal and familiar distress of what's happening with you, you're also constantly worried and stressed out about what is happening in your home country as well, which also adds to the psychological and social stress of the families, as well as the child and youth. Now, during resettlement, so once there has been a successful sponsorship and the child and youth with their families, or sometimes even with extended families, have moved to a high income country like Canada, there's continuous sources of stress and distress that could impact their overall development and mental health. It is incredibly stressful to move to a new place. Once you move in, the family needs to figure out where to live, where to find housing, where to find a job, how to navigate healthcare system, how to navigate the child's school system, how do I take public transit, where do I go to take public transit, how does one buy public transit tickets, where do I go for groceries, and sometimes, and many of the times, families have to figure out these resettlement um, drivers in an additional language. Um, for the child and youth themselves, they're also witnessing. They may not be directly responsible in terms of figuring out or finding housing or employment, but they are living and witnessing some of the caregiver and the parental stress at home and in their neighborhood. There's also, while there's efforts being made to help families resettled in communities or neighborhoods where there is existing community and resettlement services provided in their first or second languages, but there still could be a sense of isolation in terms of social supports. It may not be the same degree of social support and the community level support that the child and youth previously had, but also the grieving, the loss of, losing their home, sometimes losing their country, losing their family members. That grief also adds to that sense of isolation. But of course, it's also important for us to acknowledge and recognize that refugee children, youth, and families experience or could experience an incredible deal of xenophobia, racism, and discrimination. And from our research, we are, again, it's quite clear, and there's not a debate about it, that racialized or xenophobic stressors and trauma could also have similar impact on our mental health, like impacts such as some of the individual risk factors that we have seen previously in psychopathology studies. So what does it really mean, the impacts of these risk factors on a child's and youth's functioning? I talked about the risk factors more broadly at the post-migration level, but if you think about the first week of school for a child and youth who has just moved to this country, who had experienced months of distress and sometimes violence, what might be the first week of school look like? And in many of the cases, there's a lot of no's, and I don't know, and I cannot know that might not only further add to the stress and the distress of the child and youth in a school setting, but also really reinforces that deficit-oriented narrative that we might have for people who are minoritized and marginalized. So when you go to the school, I don't know how to find the main office. I do not know how to go to the classroom. I do not know how to use a dutang. I do not know how to use a locker. I do not know how to use the public transit or where to stand for my yellow bus to come. I do not know that I have to go to a different class to go to gym. So there's a lot of no's, and I don't know, and I cannot do no. And many of the times as adults in schools, we should be reflecting and considering that how many times we are spending time to really ask questions that what are some things that you can do? How many times we're actually optimizing and utilizing their existing strengths and resilience to give them a sense of autonomy, that there are things that you already have, that you can that would help you, that you're already bringing into the school environment. You know, um, there's a quote that I read in one of the pilot studies of the intervention that I now research, and it really stayed and resonates with me. And it says that, I may not know how to speak English, but I speak 6 other languages. But of course, our school system is structured that way, where we do have a hierarchy and supremacy for English languages, and we do, sometimes even implicitly or explicitly, we put more emphasis on a person's skills and intellectual and their abilities if they're able to speak if they're able to speak English language versus other languages. But for us to really pause and reflect at what messages do we send through those attitudes and through those conversations and policies as well. So now that we have, and of course, many of you may already knew some of these risk factors, the impacts of these risk factors could be operating at different levels. On the individual child and youth, it can also impact their functioning, interactions, and relationships with their family members, including parents and siblings, as well as their overall adjustment and resettlement outcomes. So if you break it down further at the individual level, understanding that how those systemic risk factors while interacting with individual risk factors could affect their cognitive development, whether that's in the area of attention, executive functioning, language skills, communication skills, social emotionally, our understanding and awareness of emotions, how our emotion sensitiveness, our emotional impairment. So whether we're feeling emotions in big ways, and whether we might not have the skills to even our day-to-day development appropriate skills to regulate them. Psychologically, how it's affecting, the way that we make sense of events, the way that we make sense of what we do. And then school adjustment outcomes. So academically, how we are interacting with teachers, how are we adjusting with school demands, and then of course our physical health. In the refugee child and youth literature, due to the increased risk of experiencing both individual and systemic stress and traumas, we also know that it has increased risk for developing psychosomatic symptoms, including pain experiences. So yes, it could also impact the overall physical health. In my work, I have also seen that parents who have conceived in refugee camps, or who have, or parents who have had their pregnancy in refugee camps, there is also an increased risk in those scenarios, in those cases, for the fetus to have increased stress, which might also increase the risk for that child's, once they're born, their own development, their cognitive development, but they might also have certain medical impairments as well, which then also adds a lot of stress, additional resettlement stress as well. So all of those things, again, it's not just, these risk factors are impacting and increasing the risk for PTSD or anxiety disorders or depression, but it can also have an impact on, some day-to-day developmental tasks and activities that we expect children and youth to engage in. So rather than sort of looking at like, whether or not they have anxiety or depression, but also given what we do within our healthcare capacity, but also paying attention to these developmental tasks as well as milestones. But of course, we know that every child and youth, based on diverse identities and experiences, everyone is not developing mental health disorders because it's interactions with individuals and systemic level protective factors that might exist. So acknowledging that individuals have a great amount of inside strengths, outside supports, sometimes we have seen that the relationships and the connections that people are able to maintain and hold on with their family members, or the new relationships they're forming in their communities, have a huge impact, a positive impact on their overall well-being. But also, what types of resources is available during resettlement resettlement processes could also mitigate some of the impacts of the risk factors, in terms of access to different care, overall perceived or real acceptability of newcomer communities and newcomer families, how people in the resettlement regions is interacting and welcoming people, and just what are all different coordinated services and care that are not only have been developed, but efforts have been made to make them accessible. In terms of when we think about how to provide services and support, we also need to think about the concept of intersectionality. And of course, I'm not going to go a lot of details into it, but also just, keeping in mind that there's, it's not just an idea of whether a person is a refugee or not, whether a person is a racialized or white. We have different interlocking identities and experiences that has an impact on how the world accepts us, on how the world interact with us, and some of the outcomes that we experience. Due to colonizations and imperialization, all the racialization is not experienced in equitable fashion. There is a hierarchy of race, and that is being developed, and that is a co-construction and co-creation of colonization. So we need to sort of pay attention to also other and understand, not only pay attention, but understand people's different interlocking identities, and also acknowledge that because of processes and consequences of colonization, there are also lateral racism that might exist within our refugee child and youth populations, because the colonization has created a structure and a society where there is a constant drive and need for resources, because resources are quite limited for folks who are marginalized. So if we are working with refugee child and youth groups, paying attention to lateral racism. And again, it's not something that is, a product of the East and people are just bringing it into Canada. It is something that is very much embedded into the way that our systems, our countries, the world has been co-created due to colonization. So theoretically and conceptually, knowing that there is increased risk for not only mental health disorders, but interruptions in cognitive, social, emotional, and psychological development, newcomer children, youth, and families, particularly refugee children and youth, face significant barriers in accessing affordable and quality mental health care in Canada. So, my first reflective question for you, and we'll take a quick pause, is if you are a healthcare professional or a community service provider, what are the barriers in your practice setting? And if folks would like to unmute themselves, and I'll pause here for a minute or so to say it, or they would like to answer it in their question, we can also we'll do that. But again, just for as we get this conversation going, whether you're working at a clinic, you're working in a school, you're working in a hospital, you're working in a community mental health agency or family clinic, what are some of the barriers that you think the refugee children and youth might be facing in order to access you? And then Jose, if I could also have the poll going at this point. I'm also curious that within your practice setting, at this point, how often are you providing services to refugee children and families? Okay. And then I will thank you for participating in the poll, and I'll move on to our next point. Okay.
There are a few comments in the chat box. Lack of practitioners, misdiagnosis of mental health issues, lack of knowledge of the different values, beliefs, cultural backgrounds, stigma, of course, around mental health, access to primary care providers, to complete referrals to specialized clinics, language, families' understanding of how to access our care. We don't necessarily make that as readily available to folks.
Yeah.
There's lots in there. Translation again.
Yeah. You know, I actually 2 weeks ago, I had a family who had previously received their child participated in a group intervention about 2 years ago, and the family reached out because they're having another crisis. And you know, I called up so I'm in London. I was in London that week, so I called all our local distress centers because when they were part of the clinic, we were able to provide a structured mental health intervention in Spanish, and I could tell that the parent was using Google Translator to email, but particularly at our clinic at that point, we had a clinical training who was able to speak Spanish, and that's where we were able to provide the services in group. And of course, it's a training clinic, so our clinical trainee has moved on. And unfortunately, the clinic did not have the capacity at that point to provide services in Spanish. So I'm trying to figure out, try to organize, okay, so if I want to send them these numbers, it's not helpful for me to send these numbers if they're not able to have access to interpreters. So I called these distress centers and I said, hey, I'm a clinical psychologist. I want to refer a family who's using Google Translator to tell me in service in Spanish. I mean, they speak Spanish, but they're using Google Translator to tell me they're in crisis. If I send you your numbers and tell them to call you, are you able to provide interpreters? And they were like, no, we only have English or French speakers who can do our distress calls. And that is, that's that thing that that as a healthcare professional, when, that resource that I often utilize it so regularly to other folks when I'm not able to provide that urgent care. This is something that many families who might need additional language needs would not be able to access. So, and thank you for also participating in, talking about the barriers. And it seems like you folks are quite well versed on this. So when we think about interventions and what is it that we can provide, I often think about the model of multi-tiered interventions. At the universal level, targeted level, individualized level. Universally are, more at the prevention care, skills, psychoeducation, knowledge that we can teach everyone that would promote positive mental health. And this would, be provided to everyone despite existing risks, protective factors, or strengths. However, we know that, again, due to individualized or systemic traumas or experience or adversities, some people might be already at risk of developing certain mental health conditions or challenges. And for refugee children and youth, depending on their exposure and experiences to violence and trauma, they might be at risk already coming in. So we provide more targeted intervention that might address those specific impacts of risk factors that we know that the groups have experienced. For some folks, for some children and youth, that targeted level care where they're learning skills, strategies about coping or problem solving, that might be sufficient. But for others, again, depending on their individualized or systemic experiences, they might not be at increased risk, or sometimes they might be experiencing a mental health disorder, so they might need more individualized or what we call tertiary or tier 3 level care. So when we think about locations, where do we see these services being promoted or being delivered? For refugee children and youth, classrooms, schools, newcomer serving agencies, community vocational organizations appear to be ideal places where universal mental health promotion work can be done. For tier 2, again, schools and community mental health agencies seem like ideal settings where targeted skill-based interventions can happen. And of course, again, in our current setting, what has been happening in most cases, more individualized or tertiary level care happens in hospitals or clinics. But we know that particularly for universal and targeted care, the best practice is to embed them in locations, in spaces where there is least or minimal amount of access barriers. So we want to bring universal and targeted interventions, not just exclusively in our practice settings, but we need to sort of think about and collaborate and problem solve and be innovative, that whether these universal and targeted interventions could also be brought to settings where newcomer or refugee children and youth families are already interacting. And that's why, over the past 10, 15 years, schools have been identified as an ideal location to provide both tier 1 and tier 2 level interventions because children are already there. So they don't have to worry about transportations. Parents don't have to find out additional time. It's not an added extra economical or financial barrier. So again, places we could go into the community. Now, sometimes if schools may not have the capacity to provide targeted or tier 2 level interventions, there's also conversations that we can have and brainstorming that can we have more collaborative partnerships with community mental health or community public health agencies, where folks from those agencies are going into schools, maybe as an after school program, in order to deliver the programs. So we're thinking about, okay, so how do we go and really reduce the access barriers? Even though, our tertiary level care is happening at the hospital level, but many of the times folks are not coming through the doors of our hospitals because, again, as we talked about, there's many different barriers. So can we take more innovative and strategic approaches where the referral pathways doesn't really needs to happen or start at your hospital level? What are some pathways or programs that we can develop where referral pathways can happen in settings where refugee children, youth, and their families are already accessing? Even as a healthcare professional, and maybe actually no, if I can actually have the second poll going, because I'm curious that those of you who are joining us, where are you in terms of where is your practice setting? Are you mostly providing tier 1, tier 2, tier 3, or mix of all, or one or the other? All right. Okay, so mostly tier 3. Okay, this is really important. Thank you. So even as a healthcare professional, so I, as a psychologist, often provide tier 3 interventions, whether that's trauma-informed psychotherapy or other psychotherapy modalities. But again, we know that the risk factors would also have an impact on their day-to-day cognitive, social, emotional, and relationship skill development. So as a healthcare professional, I'm also, regularly connecting with different systems of care, whether it's their school, whether it's their faith or spiritual community, or other community vocational organizations, to see that if I am seeing gaps in those developmental milestones in my therapy sessions, whether that's an individual or group, can they be connected to additional, augmented, universal, and targeted care, so that we're not only targeting the mental health distress or symptoms that are being presented, but we're also taking a more systemic level care as well. And of course, as we were saying, that when we're working with refugee child and youth, and especially the barriers that you already mentioned, the trust, the language issue, the discomfort, when we're thinking about how do we address and respond to those barriers, we have to think about these systems as not only people who we would collaborate with, but these are also folks with whom we need to address the barriers, right? Many of the times that sense of safety, mistrust, stigma, unknown, the mysteries of mental health could be coming from parents. So our work is the intervention or the programming does not, it wouldn't be that effective if we're only doing programming or interventions that only exclusively or solely addresses or respond to the child's or youth mental health. And in most cases, we have to start at the family level in terms of thinking that how do we, in a culturally responsive and trauma-informed way, begin to first respond and address some of these the discomfort, the tensions that families are having, before we sort of think about interventions that are only providing services to children and youth. So for the last part, as we're wrapping up, I'm going to sort of talk about some ideal conditions that settings can have in order to start to respond to access barriers, but also some of the components that might be that are important for us to integrate. And I would argue that this collaborative care model would not only be it will not only be beneficial to support refugee children and youth, but likely for other families and children and youth who are also minoritized and marginalized. So in your practice setting, whether you're providing universal, targeted, or individualized care or all, that's your service model. And we can sort of think about, even within your existing model, whether there is structural or systemic or deep level adaptations that needs to happen in order to make those programs more culturally sensitive, more culturally responsive. But for that, you would need additional training, consultations, education to really assess the programming that you are offering, whether that's culturally responsive or not. And then, in addition to what we do to the programming, the system of care would need additional language supports. It might need funding for transportation, especially if the specialized care that you're providing it's just not feasible to be embedded in the communities where refugee children and youth are already living. But also flexibility in service hours. Many of the times I often hear that, parenting programs may not, are poorly attended, but they're scheduled at 3 p.m. on a Wednesday afternoon. Now, refugee families, particularly parents, they have so much resettlement stressors and demands going on. Many of them are having multiple jobs, and there is higher penalty for those jobs to take a random day off on a Wednesday, and then to ask that you take that random afternoon off for 8 weeks in a row. So we really need to pay attention and assess, when are people actually free to attend our sessions? Is it helpful for me to schedule a session when I know that half of the folks who I want to provide care to would not be able to attend? Not necessarily because they don't believe in mental health, they don't care about their child's mental health, but it's just not feasible for them to do so, because they have to sometimes have to choose, okay, do I want to lose my job or do this, a parent group? And then a greater consideration is, okay, so I have my language supports. I have gone out and found funding for transportation. My staff members are flexible. Now we're adding parent sessions or interventions in the evenings or on weekends. Great. But how would I know that your service exists? How can I find you? How do I even know that this is a thing that you're offering to me? And what are all the technical and logistical procedures, like completing referral forms, that, and in order to do that, I need to find a family doctor first. How am I going to deal with all of those procedures in order to find you? So when we're thinking about making changes at our own practice setting, all of those things actually have to happen at the same time, right? Because I can spend a lot of time consulting and getting educated and develop the most culturally responsive programs. But if it doesn't come with these different tier level of systemic care, again, the program might not be best accessed by people who really need it. And in order to really do this, we need active collaboration. There's an example of a local hospital where I collaborate as a health equity research consultant, and they have identified that even though, again, theoretically and conceptually, chronic pain, and from research we know that chronic pain is highly prevalent among Indigenous children and youth, their tertiary pediatric clinic was not accessed by many Indigenous children and youth. They were seeing less than 2% of their patient population was Indigenous children and youth. So what they have done was they created a pathway, a specialized pathway, where Indigenous youth and families, self-identified Indigenous youth and families, can directly access them. And the social workers and other support professionals within that team in the pediatric hospital then work with them to find a primary care provider to develop the referral pathway. So again, another reflective question is, does your practice setting have existing community partnerships? So if you are a tertiary hospital, do you have existing partnerships with family clinics and other general practitioners who might be able to provide referral pathways? Do you have partnerships with newcomer resettlement agencies? Because that is one of the first places that refugee children and family access when they first come to Canada. There might be services for language and employment. And of course, they might not have the capacity to provide mental health care, but as tertiary provider, as a community mental health agency provider, do I have partnerships with them? What are some innovative pathways I can build in with them that, when they are seeing families in crisis, that they're able to use our partnership in able to, refer people to my services? And if you already have partnerships with other community organizations that support other minoritized and marginalized populations, what have you learned about maintaining and creating these partnerships, and what we can learn from those partnerships to create new ones that specifically provide support to refugee children and youth? At the staff level, again, these are the things that you have talked about as a barrier, is we need very intentional, and we need to invest money and time into staff training and competencies, right? Not only just learning how to culturally adopt or make our programs culturally responsive, but as a clinician, what are some things I need to consider in order to be trauma informed, in order to be anti-racist, in order to understand the newcomer mental health needs? How do I recontextualize and reconceptualize some of the mental health distress that they're experiencing, not through my westernized ways of knowing, but through the experiences that they're having? And again, we sometimes try to water down how easy it could be for people, like, oh, just go to a professional development or read a book, read a chapter, and you would know all about this. But this requires intentional learning and sometimes supervision and ongoing clinical consults. I often say that if you have a group of healthcare professionals and all of you are providing support to refugee children and youth, create a community of practice, meet every week, meet every 2 weeks. And I know everything that I'm recommending would require that time, but that is something that needs to shift in order for us to truly say that we are providing sustainable, culturally responsive care. But also, when you are thinking about bringing in programs, you need to have extra time, extra funding, and extra folks, whether they are social workers, child and youth workers, and folks with other expertise and other knowledge who would be spending more time, who would be spending additional time in our existing programming to do those referral pathways. And many of the times follow-up care. You might do a structured intervention and then still realize that these youth or these families need more work. It is not helpful for us to give them another brochure, even though if we translate their brochures in 20 different languages, because it's not necessarily that I cannot read the information, it's the barriers that I have in accessing the services that you're telling me to. So are there additional steps? Are there additional services that we can embed into our practice so those follow-up care, that we could provide more support to those follow-up care? And again, the existing programming that they're providing, there might be extending support that the program needs. Regular communication with parents, regular communication with children and youth. They might be doing the program, but halfway some other systemic or individualized problems and conflicts are come up. So when we have dedicated people that is assigned to each family member who's receiving the program, through this direct communication correspondence, we're able to respond hopefully more timely when we are having these more different pathways that people can interact with us. In terms of assessments, again, whether you are tier 1 or tier 2, tier 2 and tier 1 healthcare professionals, again, are very ideal conditions to really do those screenings and assessments to really identify that are there concerns and challenges that you're experiencing for which you need more specialized care. On the other hand, we also know that many of the screenings and assessments that we are using are developed from a westernized lens of what mental health experience is, and they may not be validated, or their psychometrics may not be assessed using the first, second, or third languages of the refugee children and youth languages. Now, I don't have a solution for that because that requires system level measurement work in order to really understand and examine the psychometrics of our commonly used instruments. So we can still use them, but would need to follow up with more culturally responsive assessments where we are asking about people's day-to-day work activities, what is coming up in the way, what is something that's really interfering. And if we are using mental health interpreters, something that I often recommend to healthcare professionals that, have those conversations with your interpreters, have your interpreters provided support for mental health care. And if they haven't, what are some additional supports that the interpreters need? I have done a lot of training with psychiatrists and psychologists who work in other parts of the world, including Africa and Asia, because they are constantly balancing the tension between using westernized materials and using them with peoples from their own region. So I think even having that level of international consultation, really understand that how do we really explain some of these mental health experiences that are very much westernized, Western knowledge heavy. And lastly, for tier 3 interventions, it's really important that we spend our time to really understand and assess people's existing strengths, but also outside supports. What are supports that are safe for them? What are supports they would like to bring in and integrate in order to do the work? But at the end of the day, people often ask me that what is the most culturally responsive treatment modality for refugee children and youth? And I would say, I do not have an answer to that because I don't think that question makes sense, because a modality on its own is not racist because it's not a live object. It doesn't make decisions on its own. What could be racist is when we use a modality that doesn't align with the person's experiences and the problem that you're trying to address. So And for that, we need to spend a lot of time to do culturally responsive assessment and case conceptualization. What is the targeted concern that we're trying to address? And as a psychologist, as a healthcare professional, what would be that intervention's mechanism of change? Does that mechanism of change make sense with the person's targeted concern? If the targeted concern has nothing to do, with catastrophic thinking or irrational thinking, then I'm not going to use a treatment modality that has a heavy emphasis on that, right? And that has a huge implications if you're working in settings that has much more of a rigid and strict emphasis on manualized care, because we cannot guarantee that our manualized intervention would work for every individual's. And I don't think this is only concerning refugee children and youth. I think that works for everyone, right? We cannot say that this would work for everybody. It really depends on our mechanism of action. And lastly, to talking about stigma, we talked a lot about this is, yes, there could be internalized stigma. And some new research that's coming up is, some researchers have begun to ask that, why is it that you wouldn't access mental health care? And one reasons that come up is there could be some possibility that due to experience and exposures of one mental health is parents and caregivers may attribute some of the behavioral and mental health problems that they're seeing in their children and youth to their own parenting, to their own experience. So if we dig deeper into that, what's really happening, parents or caregivers may experience embarrassment or shame in accessing care. There might be also other misinformation that people might have that, if a child has anxiety or depression, your doctor would call child protection services. If a child has this, the child protection services might get involved. So which means, again, working a different system. One of the prevention model that could work for newcomer children and youth and families is just providing basic psychoeducation on what is mental health and what are some of the contributors of mental health problems. And sometimes mental health problems have nothing to do with bad parenting, right? But also, I think about external drivers or stigma. If I have this stigma that, there's something wrong with me because I have this mental health issues, or people will not take me seriously, or people will not be kind to me, people would be judgmental. We can also reflect that within our setting, are we unconsciously or consciously interacting in ways that actually reinforces that stigma narrative? And that's why culturally responsive care, relational based care, really helping our staff and our colleagues to really address some of the biases, incorporating anti-racist care is really important, because those clinical and systemic level practices are also equally important in order to reduce the stigma. It's not only the job of our refugee child and youth families to really overcome their stigma, but it's also something that we need to do systemically. And on that note, I will end, and I apologize. I am running I am a bit delayed, but I'm here to answer questions, but also happy to have ongoing conversations with folks about the topic.
Thank you so much. We've gotten a number of very positive comments about how much needed this presentation was and how grateful folks are for your sharing. I see we've got a couple of questions coming in. We probably only have a chance for one of them, but Jose has a final poll to launch for our remaining attendees. And while she's launching that poll, I'll just get that question handy. It's from Andrea, who unfortunately had to leave, but is really keen to hear the response when she listens to the recording.
Mm-hmm.
From a public health lens, what's the one thing we could do that you feel would have the greatest positive impact on refugee children and their mental health? And she notes that she's from a small Ontario community of about 45,000 with little or no refugee services for youth.
Yeah, I think from a public health perspective, I would really focus on tier one prevention and universal interventions. So whether there could be collaboration between public health nurses to go into the schools and provide either universal or targeted mental health literacy or mental health skills development. I think that would be a starting point if we can provide some targeted targeted preventions in that lens, because again, we need to, and in a setting like Andrea's, we really need to focus on a place where refugee children and youth are already there, and schools would be one place. And public health folks can consult. There are a few structured mental health interventions, both at the prevention and targeted level, that has been uniquely developed for to manage the distress of newcomer children and youth. So that would be a first place for me as well. But also another thing that I would also again, this is based on resources and capacity, is what are some tools, culture responsive knowledge mobilization materials that we can provide in order to explain how to access mental health care services for refugee children and youth and families? So if I am feeling that something is up with my kids, who is the first person I can have a conversation with? What are some, is it okay if I ask for an interpreter? Do I have the right to ask for an interpreter when I go see a family doctor? Actually, at Western University, there is a new website. It's called Newcomer Health Hub, and it's a website that has been developed by students in medicine to help newcomer families navigate and learn more about the healthcare system. So even tools like this would be helpful for people to get an initial understanding of how to access services.
Wonderful. Thank you so much. That's the end of our time today. I want to thank you, Maisha, for sharing your time and expertise. And as I said, we've gotten a number of really positive comments. I want to thank our audience members for joining us today and staying till the bitter end. We know how busy you all are, and I hope that this was helpful and you depart with some practical knowledge to bring right back to your organizations. Just before we break for our summer hiatus for July and August, we will be releasing Navigating the Child and Youth Mental Health Crisis, Challenges and Opportunities, which will see Dr. Catherine Smart in conversation with our special guest, Dr. Javeed Sakura. And so we look forward to seeing you back here in September when our webinar series resumes. We want you to have a lovely summer. Stay tuned for our details about upcoming Spark webinars. It's always great if you can watch, as your questions and comments really enrich the discussion. But if you can't, the recordings are made available on our website within a week after the fact. So thanks for joining us today. Thanks to Maisha for this presentation. And hopefully we'll see many of you back here in September. Bye, everyone.